Good morning, and welcome to the UCLA Health webinar, It's Not Child's Play, an evidence-based approach to youth sports concussions. I'm Dr. Chris Giza, professor of pediatric neurology and neurosurgery at Mattel Children's Hospital, UCLA, and the director of the UCLA Steve Tisch Brain Sport Program. I'd like to welcome you to learn a little bit more about the medical aspects of concussions occurring in youth sports. This is an overview of what we're going to talk about today. We're going to talk a little bit about general information about concussions, what to do when you initially evaluate an athlete with a concussion, what's the management and how do you return them to play and return them to activity, including school, what are the real risks for chronic problems, and then we'll wrap up. First thing to remember is there are 4 R's for sports concussion. You have to recognize the signs and symptoms so you identify that a concussion has occurred. You have to remove them from play, and the purpose of that is not to prevent them from doing activity, but is to prevent them from having a risk of repeat injury. The 3rd R is recover, and the 4th R is return to play and return to activity, which for most of our kids will involve returning to school. Here's a little video of a concussion. Okay, so you're focusing on the ball handler, but it's actually the other player who's running along. Not really looking in one direction, he kind of gets hit. He's not able to brace himself, and you see the bobblehead effect, where his head kind of bounces around and he gets an injury. And that's actually, in a nutshell, what a concussion is a brain movement injury. So the important thing when you're meeting with parents, often later this summer when you're doing pre-participation physicals, is to make sure they understand what a concussion is. It's a brain movement injury. We recognize the clinical syndrome where symptoms start quickly. You don't have to be knocked unconscious, and that's a common misconception. Less than 10% of diagnosed concussions actually have a loss of consciousness, so that's important. Another thing that's important, and we don't emphasize it sometimes in the newspaper, but it gets better with time if you don't get whacked again. So again, the important thing is to protect an athlete who's suspected of having a concussion from returning to play prematurely and then having a higher risk for a subsequent injury. And CAT scans are generally normal. We'll talk a little bit about the role of imaging in the acute evaluation of concussion. Now, the signs and symptoms of concussion most people are aware of. Headache is the most common, but dizziness, nausea, being disoriented or confused, having slurred speech, having problems with your balance and coordination, slowed reaction time, memory impairment. And of course, as I mentioned earlier, if you're knocked unconscious, that's obviously going to be a concussion, but you don't have to be knocked unconscious to get one. And so this constellation of symptoms in somebody who recently had a collision should prompt the suspicion for concussion. And on the sideline, that means if in doubt, sit them out. Now, who gets sports concussions? Well, based on sport, obviously football is associated with a lot of concussions, but you can see that no sport is really immune. And of course, there are plenty of concussions that occur outside the setting of organized sports: bicycle accidents, falls, motor vehicle accidents, and other things. When we look within sports, we tend to think of concussions as a boys' problem, probably because of the concussions associated with football. But if you actually look at sports where the rules are the same between boys and girls, so soccer, basketball, baseball/softball, if you look at the rates of concussion, you see actually girls tend to have a higher rate of concussion. And if we look at the amount of concussions per 1,000 games or practices, so this is per athlete exposure, what you can see is these are the different sports. H represents high school, C represents college. The sports that have the same rules between boys and girls generally have a higher risk. We don't know exactly why that is. Some hypothesize it's due to neck strength, some due to differences in symptom reporting, some due to hormonal differences. It's not clear, but the trend is definitely there that girls have a higher risk for developing a concussion, and so we shouldn't think of it as just a boys' problem. All this kind of information is important to give to families at the beginning of the season so that they have proper information for understanding the risk that their child may have, and also noticing that their sports have different risks. So combat sports haven't been studied but probably have the highest risk. Then collision sports like football, rugby, boys lacrosse, things like that. Then there are sort of contact sports where hitting another player isn't part of the game, but it can occur. So for example, like basketball or soccer, and then non-contact sports like baseball, track and field, and things like that. So you've given your family some information at the beginning of the season. Now something happens. So what's the initial evaluation? Most of the time there won't be a medical professional right on the sidelines. So the initial evaluation will occur in an emergency room setting or an urgent care setting. The first thing is to make sure the athlete is okay. Make sure that sort of ABCs, airway, breathing, and circulation. Make sure it's not a more severe injury than a concussion. By the time when the athlete or when the patient then comes to the emergency department, there's a question of whether or not a CT scan needs to be performed, and there's good evidence-based rules for determining the need for CT scanning after mild pediatric traumatic brain injury. This is actually should be greater than 2 years of age. So kids greater than 2 years of age, if they have an altered mental status, a Glasgow Coma scale that is not 15, or a basilar skull fracture, there's about a 4 to 5% risk of having a clinically important traumatic brain injury. That is a brain injury that involves bleeding or may require surgery or ICU hospitalization. And in that setting, a CT is recommended. If they don't have any of those characteristics, then you go to a second tier of questions. Was there loss of consciousness? Is there vomiting? Is there a severe mechanism of injury or a severe headache? Severe mechanism of injury would typically involve being ejected from a car or a fall greater than 3 meters. So in a sports setting, it doesn't happen very often, except perhaps by being struck by a high velocity object like a baseball or something. If the answer to any of these questions is yes, there's less than a 1% chance of a clinically important brain injury. So that creates a little wiggle room where you can either clinically observe the individual or do a CT scan. And that decision is based on multiple factors. If none of these are present at the time the patient presents to the emergency room, then the risk of a clinically important TBI is vanishingly small and a CT scan is not recommended. In any case, a CT scan is not recommended to diagnose a concussion. Okay? It's only to be used if you suspect that there's a problem more severe than a concussion. Now, how do we determine then whether a concussion occurs? We've heard about baseline tests, computer tests, this, that, and the other thing, but it turns out there's no single test to diagnose a concussion. Okay? There are different parts of the brain can be affected differently. Balance may need to be assessed, eye movements, reaction time, symptoms, neurological exam, cognitive testing. All of these things are part of your toolbox to assess concussion, but the diagnosis of concussion remains a clinical diagnosis. There's no single test. One of the commonly used tools to help evaluate for concussion is the Sports Concussion Assessment Tool, and this is a version 3. The individual components of it have been validated, and one of the main first parts of the SCAT-3 is the symptom evaluation, where you ask 21 different symptoms graded from 0 to 6, with 6 being the most severe, and trying to compare that. If you have baseline information, that can be helpful, but within the first couple days after concussion, if that number is greater than 10 or more than 4 or 5 points above what the athlete's baseline, then you should have suspicion that a concussion may have occurred. The second part of the SCAT-3 is the Standardized Assessment of Concussion, or SAC. This is a miniature cognitive test that focuses on attention, memory, orientation, and is relatively simple here. You ask where they are, you give them 5 words. If you look at the SCAT-3, which you can download for free on the internet, it has word lists that you can use. Then you can do digits backwards. You take a little break, during which you will do your neurological exam, which can include eye movements and coordination. You may also, at that point, do a balance assessment. The balance assessment is called the Balance Error Scoring System, and in that, the athlete would assume 3 different stances, each for 20 seconds with their eyes closed, and you would score when they made errors in balance, which could include opening their eyes, bending, hands off the hips, foot touching the ground. These type of tools, I don't expect you to go right after this webinar and start using them. I hope you will go to the website, you will go to the papers and read how to administer this test and become familiar with it before you start using it. But both of these are helpful in assessing concussion. Once you have completed the balance, you need to remember to go back to the standardized assessment of concussion, and don't forget to ask the 5 words again for delayed recall. Now, you've probably also heard a lot about computerized cognitive testing. In fact, many schools have chosen to use this as their sole way to manage concussions, as they will administer computerized cognitive tests to athletes at the beginning of the season and then look at those numbers if they suspect an injury occurred. There are many brands, so one is not clearly better than the other. If you are going to use this, you should be familiar with it, just like any other tool. If you're going to interpret an X-ray, you have to make sure you're familiar with how to interpret that. If you're going to use a computerized cognitive test, then you should know about it before you start using it. There are ways that these tests can be fooled, where they are not accurate. And some of the things that we know are, for example, children with learning disabilities may not pass the concussion test even though they've not had a concussion. Okay? Another circumstance where people can score poorly and has been published in the peer-reviewed literature is if there's an orthopedic injury. Sometimes just the pain of an orthopedic injury, perhaps the anxiety of whether or not you're going to be on the team is enough to reduce your memory score on some of these tests where it would appear as if you were concussed even though it was a non-concussive injury. A third and somewhat kind of humorous study was published using micturition urgency. The athletes had to pee really badly. They were required to drink a certain amount of liquid, and then they had to take the computerized cognitive test, and you can fail the cognitive test if you have to urinate very badly. So it's important to know the limitations of these tests. They are a tool that you can use, but they do have limitations. Let's look at another concussion. Now this is in girls, and what you can see is it's not really the header, but it's the collision. And in here, she collides, and then it's her head hitting the ground. Okay. So concussions do happen in girls, and they don't have to be involved with headers. So now you've done an assessment. You've determined that your patient, the child, has had a concussion. What's the management strategy? How are you going to take care of them? Well, the first thing in pediatrics, we're pretty familiar with the idea of anticipatory guidance. You want to instruct the family and the patient what to expect. And what to expect, for the most part with concussions, is that they will get better. 3/4 of high school athletes get better within a couple of weeks, and that goes up to 80–85% in 3 weeks. So it's important that people have the proper expectations. A single concussion is not a doomsday scenario for most people. It's also important that this information be given to them objectively, often with both verbal and written instructions, as early after the injury as possible. This is a complicated slide, but essentially what it's showing are, on the y-axis, different measures of symptoms or behavioral change. Okay? And really the two groups to compare are the green and the red bars. The green bar is the group of kids who had an injury and then got a brief intervention with education, anticipatory guidance, written handouts, etc. And the red bar is the group that didn't get that intervention. And what you can see is for many of these different things, the group that got the brief psychological counseling and information had fewer symptoms and fewer problems at 3 months. In fact, using this type of what we call cognitive restructuring, you can reduce by 15 to 20% the number of individuals with concussion who develop chronic post-concussion syndrome. So a very simple upfront intervention that can be done in anybody's office. You make sure you give them the right information, and you can reduce the likelihood of them being one of those individuals with chronic symptoms. Now, why is it important to keep an athlete away from the sport when they're concussed? Well, we know a few things. We know their balance can be off, their judgment can be off, their reaction time or reflexes may be slower. Okay? Their brain may be biologically more vulnerable. And so what happens is if an athlete who goes back prematurely has a higher risk for a repeat concussion. In fact, for in-season repeat concussions, a high percentage of them occur within the first couple of weeks, that time period when the athletes are symptomatic. The other thing is that if you have a concussion on top of another concussion, it actually takes you longer to get better. Okay? And you can see here So in red, this is the proportion of individuals who took longer than a week to get better. These are college athletes. But you can see based on the number of concussions they have, the more concussions you have, the harder it is to get better quickly. Okay, so those are the reasons to avoid going back too soon. Better to miss a week and get better and heal fully than to go back prematurely, get another injury, and then miss multiple weeks or miss a big part of the season. Now, there are risk factors for prolonged recovery. Okay, so we know that there are certain things you can get from your medical history that will inform you to expect this athlete might take longer. It's not automatic, but it's good to know. If they've had prior concussions, I already mentioned, that could take longer. When they say younger age, these are studies comparing high school to college athletes, and it appears that high school athletes take longer than college athletes. Symptoms of headache, particularly migraine symptoms with light sensitivity, nausea, vomiting, and dizziness, are associated with more prolonged recovery. The symptom of fogginess on the symptom checklist. On the field, mental status changes, history of prior headaches or learning disability, symptom of dizziness. We also ask about psychiatric and behavioral problems, including depression and anxiety. All of these things, whether they're present after the concussion or whether they were there before the concussion, can contribute to having a longer recovery. Once your athlete has had a concussion and you've sat them out from play and their symptoms are slowly improving, what's the general consensus on how to start returning them to play? So, in general, they are not to return to play the same day of injury, and they go into level 1 of these consensus-based guidelines. Is a symptom-limited rest, is that they may stay home from school briefly, they don't do any physical activity for the first day or two when their symptoms are the most. After that, based on after the medical assessment, you can start to advance them through light aerobic exercise. Let me go back. Light aerobic exercise. Then if they do that without having worsening of symptoms, you can add a vestibular component. You can have some movement so they can start running. If they do okay at that level, then they can go to non-contact training drills, which require them also to have some cognitive effort. The big cutoff here is between 4 and 5, because prior to number 5, there shouldn't be very much of a risk of getting another concussion. In order to progress to full contact training, then they need to be completely medically cleared. Now, how long do you spend at each level? Well, it depends a lot on symptoms. Most people would like to see the symptoms pretty much gone before you start advancing, although they don't have to be completely gone. Okay? And at the collegiate level, they use about 24 hours at each level. I mentioned earlier that high school athletes take longer to recover. So along the lines of trying to err on the side of being conservative, we would recommend maybe 24 to 48 hours at each level as the maximum speed which one of those athletes would recover. And often, the way we handle this is if I see an athlete on a Monday or Tuesday after a concussion on the weekend and they still have some lingering symptoms, I'll tell them right up front that we're going to go through the return to play as their symptoms get better, but they're not going to be able to return that weekend. Just take that off the table right away. There's no way to advance through this between Monday and Friday fast enough to get back safely. Now, there's been a lot of talk about recovery being complete rest, total cognitive and physical rest, and that premise is changing into the idea of a more active recovery, so that if you look, this is some measure of injury over time, and there's a threshold for symptoms. Of course, in the first day or two, the symptoms are highest, the injury is most acute, and that's a period where you probably want to rest, and you're limited by the amount of symptoms you have. And then as the symptoms start to recover, they may not be completely gone, but you can start doing some activities, particularly activities that don't worsen your symptoms. So kids can start to read, they can start to do a little bit of homework, maybe they go back to school part-time, maybe they start to do some gentle aerobic exercise. And then gradually as the symptoms go away, and sometimes this relative activity may help them get better faster, but as their symptoms then go away, then they can go into the gradual return to play protocol that we just talked about. Now, there's actually some real data to help guide us in terms of how much rest kids need. And so this is a prospective study that looked at over 300 kids who had concussion and had them just keep track of what their activity was as they got better. Then they divided these kids up into quartiles, and they wanted to see, was there any group that took longer to get better? And it turns out there was. You can see here the kind of yellowish orange group took more time to get better than the other 3 groups. This group is the group that had the highest level of activity. So the kids who didn't tone it down at all seemed to take longer to get better in this study. It did not matter the bottom 3 quartiles. You didn't have to be a couch potato to get better faster, just as long as you kept it down from extremes of activity. Now, a more recent study that was published just earlier this year actually did a randomized controlled trial. They took usual care, which was, as I mentioned earlier, 1 or 2 days of symptom-limited rest, and then gradual reintroduction to school, and then gradual reintroduction to physical activity, versus a group that was given instructions for strict rest 5 days. Don't go to school, no texting, no homework and things like that. And what you can see here is the proportion of each group that's becoming asymptomatic. You can see that the standard care group is getting better, it gets to the 50% point, about 2 to 3 days faster than the group that was told to rest strict for 5 days. And in fact, what this study found was that when you tell kids they have to stay home for 5 days without doing anything, they end up reporting more symptoms every single day they're home compared to kids who have gradual return to activity. So the recommendation is, again, some brief symptom-limited rest, but not keeping them out of school for prolonged periods of time. This is our algorithm that we try to follow for our UCLA Steve Tisch Brain Sport program. The first couple of days is symptom-limited rest, okay? Little work or no work. Now, obviously, some kids are already asymptomatic very early. You can challenge them a little more. These aren't absolutes. After some rest, they do the beginning recovery phase. They can start some cognitive effort. That may mean doing homework a little bit. That may mean partial return to school. All the time monitoring symptoms and making sure that the symptoms aren't flaring up. Then they get into gradual activity. Now you're increasing the cognitive effort. Perhaps they're back in school more or less full-time. You're still monitoring the symptoms. Maybe we start to do some non-contact, no-risk exercise. Particularly for kids who are devout athletes, if you sit them down for days and days or weeks and weeks, you create a lot of other problems. That you create mental health issues for anxiety, whether they're going to be able to return to the team. They get out of shape, so then they might be dizzy, or they might not be able to tolerate exercise as well. So it's good once they're getting back on track, going to school, symptoms are coming down, that you introduce some no-risk or low-risk exercise so they can maintain their conditioning. And then, obviously, you want to return to normalcy. This is the goal for everybody. So we don't want kids sitting at home in a dark room, not doing anything, unless they're in an unusual case where they're having very severe symptoms. And in those cases, referral to a specialty center is probably helpful. But for most kids, we want to move them down this progression so that they can be back in school, taking their classes, and then also beginning that return to play progression if their intent is to return to their sport. Now, parents often will also ask, what are the long-term risks of sports participation? And this is a good question, and this may actually be something that you end up talking to the parents about at the initial evaluation. Sometimes they'll ask you right up front, Johnny's going to play football. I'm worried he's going to commit suicide or that he's going to have dementia later on. So what are the real risks for chronic problems? Well, chronic post-concussion syndrome or chronic post-concussion symptoms occur in a minority of patients who've had concussions, maybe 10, 15%, some groups as low as 5%, but in that general range. It turns out that it's often associated with premorbid conditions. So as we showed you earlier, the list of risk factors for prolonged recovery includes things that the athlete may have had already. History of migraine, history of a learning disability, history of anxiety or depression. Things like that may actually be worsened or flare up after a concussion. They should be treated. Okay? The pattern of symptoms usually is the acute symptoms of the concussion are maximal and then they get better, but then if you notice 2 to 3 weeks out, new symptoms are popping up or other things like that, those probably aren't to be attributed to the concussion per se, but may be related to other pre-existing conditions. Headache is a prominent feature of post-concussion syndrome. It is not a prominent feature of chronic traumatic encephalopathy or dementia. And of course, sometimes a headache is just a headache, right? People get headaches, people are tired, people get dizzy for different reasons, and so if you have patients who are complaining of new symptoms weeks or months after a concussion, it may be that those are just regular everyday symptoms like everybody gets, and they should not necessarily be attributed to a concussion that occurred months ago. Okay. Now, chronic traumatic encephalopathy is sort of the elephant in the room. This has been described in multiple cases on autopsy. There is a protein in the brain which shows up here as brown. It's called tau, and it's associated with neurodegeneration. And you can see tau accumulating in individual neurons. This is the largest peer-reviewed case series of chronic traumatic encephalopathy published by Dr. McKee. And there are 68 out of 85 brains that were examined had evidence of tauopathy. Okay. This would seem to be a pretty alarming proportion, but you have to remember for case series, getting into the study depends on, number one, in this case, that you had to die and there was an autopsy and your brain had to get into a certain pathology department. Another study which did a similar thing, they looked at brains of retired professional athletes that were in their brain bank, and they found a much smaller percentage. They found 0 out of 6 had isolated CTE, and only 3 out of 6 had CTE combined with some other neurodegenerative condition. And so this is the challenge when you're doing case series, is that you don't know what are the criteria for a case to end up in a particular study, and it probably isn't generalizable to the regular population. So this is a worrisome condition. Obviously, nobody wants to get it, but we don't have a great idea of what's the actual risk, and is the risk the same for kids as it is for professionals? Case report and case studies can't tell you what the relative risk is. Okay? So I can't say that this study is correct or this study is correct, even though they have very different results. What we do know is that chronic neurocognitive impairment has been reported in people while they're still alive. And this is usually done by measuring neuropsychological tests or behavioral questionnaires in individuals who are still alive. And it turns out when you look at professional sports and the studies that are published, there is an association with playing football, soccer, rugby, professional horse racing, boxing, and scoring lower on a neurocognitive test while you're alive. Okay? And this is pretty strong for professional sports, and it appears that the longer that they participated in the sport, or the bigger dose of the sport they got, for example, more fights a boxer had, or more concussions that a professional jockey had, their neurocognitive scores were lower. The flip side is when you looked at the number of studies that were done in amateur athletes, only half of them found chronic cognitive impairment and the other half did not. And so I think this doesn't mean that it's good or it's okay to hit your head a lot of times if you're an amateur athlete, but it means the risk is probably less. Okay? And the evidence for these are pretty strong because there are multiple studies, probably over 30 or 40 studies. Chronic traumatic encephalopathy, or CTE, which of course we all worry about as a progressive neurodegenerative disease, but right now it's only able to be diagnosed post-mortem, and we don't have a causal link established. And the current data are only those case reports and case series that I showed you earlier, which by the nature of how that data is gathered is lower quality data, is class 4 data versus class 1 and 2 data for the neurocognitive impairment. So we want to limit the amount of exposure people have to repeat injuries, but it doesn't invariably lead to dementia. And it may be very important actually for us to protect the athletes so they don't end up having injuries on top of injuries. That may be one of the most effective ways to limit this type of problem. So here's a little algorithm for an approach to concussion management. You have your initial contact with the family, the pre-participation exam. You give them the objective information that you know, the risks of the different sports, how to recognize a concussion. If you suspect a concussion, when in doubt, sit them out. You examine them. You look for those comorbidities that we talked about. Maybe you use the graded symptom checklist, the standardized assessment of concussion, the balance test, neuropsychological testing, as part of your pre-participation physical, so you have a baseline. Okay? Then an event may occur. On the sideline, you don't have to diagnose a concussion. You just have to suspect it, and the athlete should sit out until they get medical evaluation. There's an initial medical evaluation, hopefully by somebody who has some knowledge in concussions and can use some of the tools that we talked about. And then, like any diagnosis, you have a range of likelihood of there being a concussion. Okay? Sometimes we'll say there are things that might or might not be a concussion, we're not sure. To err on the side of caution, we'll manage them all like they were concussions, and particularly those that are at the sort of higher probability. Once a concussion is diagnosed, that athlete is protected by not returning to play prematurely. You do serial assessments to monitor their symptoms. You treat the symptoms if necessary. You manage their activity. And you would also treat comorbidities if they have problems with migraine, if they have attention problems. You don't want to ignore those during the recovery phase. Eventually the symptoms improve or recover, and when the symptoms have resolved, and during this phase, they may be, as you're managing the activity, they may already be returning to school, they may be returning to low-risk physical activity, and once the concussion is resolved, then they'll do that gradual return to play and potentially be able to return to full participation. Now, sometimes they get stuck here and they don't get better, and that's a good time to refer them to a multidisciplinary specialty clinic. Another possibility is you're not sure at the initial assessment whether it was a concussion or not. And so there is a subset of individuals where they have symptoms that end up not being a concussion. And it could be something else. Hyperthermia, migraine, fainting spells, anxiety, learning disabilities, other things. And if it's one of those other things, then you should identify and treat one of those other diagnoses. Okay, so we're ready to wrap up. In summary, concussion is a clinical diagnosis. Remember, there's not a single test. You have to use all your tools. And the manage can follow evidence-based guidelines like I've shared with you, but it should be individualized to the patient. Again, no single test for concussion. Fill your toolbox with multiple tools that would allow you to diagnose concussion, and then put that together with your clinical practice to make the diagnosis. Remove the athlete from contact risk to avoid the higher risk for a repeat concussion and potentially longer or more severe symptoms. Provide anticipatory guidance, education, reassurance, objective information to reduce by 15 to 20% the likelihood that the individual gets chronic post-concussion syndrome. Manage the comorbidities. These comorbidities often predict longer recovery, and so we ignore them at our own peril. If somebody's got migraines, if somebody's got anxiety, and their symptoms are lasting longer, we should treat those. There should be a gradual return to activity, as we outlined, and avoid prolonged school absence. We know that sometimes if you keep people out too long, you ultimately end up really prolonging their recovery. And lastly, we know that there are some long-term sequelae showing cognitive impairment during life in professional athletes. It's uncertain in amateurs and youth, but we want to err on the side of being cautious. So the best head injury are the head injuries that don't occur. This little hockey video will tell us about it.
This potato sack doesn't have regulation in it. Excuse me? Well, it's got a wider base, and that's totally unfair to my kid, right? I want to launch a protest.
He's taking this pretty seriously.
It's 2 inches higher, and look at those hand grips. It's not regulation. Regulation? Look, you know what else? I want a urine sample from this kid.
Uh-oh.
He looks a little beefy for a 5-year-old. We're going down, buddy.
You're going down, buddy. Just remember, it's just a game. Thank you for your attention. Here's our brain sport contact information, and I'll take some questions now. Okay, so if you want to send questions in, I'm supposed to let you know, you can use hashtag UCLAMDChat. Okay? Now, we have a number of questions here, so I'm going to read them out and then give you a brief answer. So one of the questions is, what about concussions in toddlers and little kids? What are the symptoms, and what should we watch for after a fall? That's very tough, okay, because younger kids often don't have the same verbal repertoire to be able to explain their symptoms to us. Obviously, I guess holding one's head, unexplained nausea or vomiting, instability. Again, toddlers sometimes are a little teetery anyway when they're walking, so a lot of times we rely on somebody who knows the child very well. A parent can often tell when the child is acting a little strange, and we look again for those type of things: headache, nausea, vomiting, unsteadiness, things like that. Next question here is there a high risk of concussion when practicing in full contact martial arts? That's a great question. And it turns out there's very little data on that. So when I listed the sports in relative order of risk, the reason why you didn't see boxing and full contact martial arts at the top of that list isn't because there's no risk in those sports. Obviously there is. No one has done a study to quantify what that risk is. But in a full contact sport where one of the goals is to strike your opponent in the head or neck, then obviously the risk there should be higher even than a sport like a collision sport like football. Third question is, do concussions cause Parkinson's or Huntington's disease? This is a good question too. First of all, I'm going to take the Huntington's disease part out because the Huntington's disease we know is a genetic disorder and it's not really been associated with environmental exposures like physical trauma. There have been some association possibly with toxins in the environment. But Parkinson's is different because everybody knows Muhammad Ali, who appears to have concussion, or who appears to have had many concussions as part of being in boxing and appears to have a form of Parkinson's disease. So it turns out that having head trauma, like moderate to severe head trauma, can be a risk factor for developing Parkinson's. We don't know whether or not milder head trauma or repeated milder head trauma can be associated with Parkinson's. So probably an individual concussion here or there, especially if there's full recovery in between, would be pretty unlikely. But research really is underway now to figure out whether or not repeated injuries, particularly with incomplete recovery, can add up over time and result in something like we see in boxers. Which part of the head is most susceptible to concussions? Okay, that's an interesting question. It's hard to answer. It turns out that your brain floats in your skull. Your skull is like, I tell patients, think of it as a pickle jar with fluid inside, and your brain is floating in that fluid. And so when that skull moves, the brain moves around inside. And if the brain moves around inside, then there's a brain movement injury. Okay? And so you can't avoid brain movement just by putting a helmet on it. So that's one of the challenges with figuring out what part of the head is associated. We know in football, tackling with the crown of the helmet seems to be associated with a higher risk for concussion. And then we also know from other sports that rotational movements seem to be associated with higher risk for concussion. Okay. Okay, what are thoughts about supplements such as omega-3s for prevention and treatment of concussions? That's a good question. The short answer is omega-3s have not been proven to make you get better from a concussion faster. Okay? They don't have really any dangerous side effects necessarily. They're a naturally occurring substance, so there's not much of a downside from taking them, but they haven't been proven. Some animal studies have suggested omega-3s are good. Omega-3s are an important part of brain membranes, and there are longer-term studies of cognitive health. So studies looking at dietary effects across years of one's life and trying to show what kind of dietary factors are associated with longer cognitive preservation as you get older. And it turns out in those kind of studies, omega-3s are helpful for delaying the onset of dementia as you get older or for maintaining cognitive function. I think there's not much harm in taking them, but they're not proven that they're going to make your concussion get better faster. Another question, how many concussions before you retire? Okay. It depends on a lot of factors. I have some colleagues who say one concussion in my kid is too much, and others who, if their child is getting lots of benefit from participating in sports and the concussions are diagnosed promptly and they're protected during the recovery time so that there's no accumulation of concussions on top of concussions, they may be able to be medically cleared after multiple concussions. So there's no magic number that says, 3 strikes, you're out. And a lot of it depends on a balance of what's the benefit the child is getting from sports participation versus the risk from injuries. Do you have to be knocked out to have a concussion? As I mentioned earlier, you don't have to. So less than 10% of concussions that are diagnosed have a loss of consciousness. So headache is the most common symptom, and some of those other things we talked about, dizziness, disorientation, memory problems, and stuff like that. Parents often will ask you if your child plays football or soccer or some sport that involves contact to the head, will they develop dementia? I think we talked about that during this webinar, is that there are obviously some case reports where this seems to happen. It seems that developing cognitive impairment while you're alive is associated with a higher level of exposure, typically a professional level of exposure to the sport, and it doesn't happen for everybody. So there are other factors that we're not aware of, that some people are more susceptible to the consequences of repeat concussions and others are relatively resilient. And then the last question I see here is, are younger kids more prone to concussions than adults? Okay. And we don't know that they're more prone to concussions. What we do know is, in general, they take a little longer to get better. So most of that data is based on studies of high school athletes compared to college athletes, and the high school athletes seem to take longer for symptom recovery than college athletes. We don't know about much younger kids, but there are some studies from emergency rooms that suggest that grade school kids tend to recover faster than high school kids. So it may not be sort of a unidirectional risk that the younger you get, the longer it takes you to get better. Maybe because high school kids have a lot of other things that they're concerned about, that may pile upon in a setting of concussion and lead to more prolonged symptoms. And it seems that maybe some of the younger kids may get better or may recover from their symptoms more rapidly. So I think that gets to the end of all of our questions. So I want to thank you for participating in the webinar. And this will be posted up on the UCLA website, so you can access it whenever you want to. So thank you very much for participating, and goodbye.